Well, thanks so much, Peter. And today I'm going to tell you why you should be excited about our new advances in topical therapy. I run the clinical trials at Henry Ford Health System in Detroit, and these are my relevant disclosures. So I'm going to start out by talking about what are some key tips. What do you really need to know about topical therapy? First of all, one of the basics. Vehicles matter. And just to take a step back and think about topical therapy, we understand that this is a marriage of the active ingredient and the vehicle, and each of them plays an important role in the efficacy, the tolerability, and the patient acceptance of the drug. If we look at betamethasone dipropionate, we can take one active molecule and take it anywhere from a super potent steroid all the way down to a mid-potency steroid just by changing the vehicle. And we can't necessarily predict which way the potency is going to go by looking at a particular vehicle. For instance, here, when we look at the spray formulation, it's a class 3, but look at desoxymethasone. You take that and put it in a spray, and now it's a super potent steroid. There's a general misconception about topical steroids, and that is, if you have generic clobetasol, you don't need anything else. That's all I need for my topical psoriasis therapy. But the truth is, combination therapy is better. If we can utilize two different drugs that work by different mechanisms of action, in general, we're going to get a better efficacy and we're going to get a better tolerability profile. We have two types of fixed combinations. We have calcipotriene with betamethasone dipropionate. These work by different complementary mechanisms of action, and they tend to neutralize each other's side effects. And the same is true with tazarotene and halobetasol in a lotion formulation. When we look at what we have in terms of new innovations of the fixed combination of calcipotriene and betamethasone dipropionate, we have something called pad technology, which allows us to use an elegant cream, but still getting the safety and efficacy of the fixed combination. And then we have a foam formulation, which is probably the most potent of the topical treatments for psoriasis. So what is pad technology? If you want to make a cream formulation, you have to take an oil and put it in water. And we know that oil and water doesn't want to mix, so in order to do that, we have to add a lot of surfactants. And the problem with that is surfactants can be irritating and they can impede penetration. With pad technology, we actually create a robust oil droplet that allows us to use much less surfactant, get better penetration, and create an elegant cream vehicle. This pad technology was utilized for the fixed combination of calcipotriene and betamethasone dipropionate. It was studied not only versus vehicle, but also versus the active control of the same fixed combination in the suspension. Treat once a day for 8 weeks, and we found that with this pad technology, not only did we have a more elegant cream vehicle, but we also had a statistically more efficacious topical as compared with not only with the vehicle, but also compared to the suspension. Remember, psoriasis is itchy, and our efficacy on itch is equally as important, and we saw a nice improvement with itch as early as the first week. In terms of the side effect profile, we know that these topicals can be irritating, but with this cream formulation, we actually had an irritation profile that was not that much different than the vehicle. Something else that's important is that proactive therapy works. When you treat a patient with topical therapy and you get them to clear, almost clear, what do you do next? And a lot of us will say, well, we either give them a holiday or we go ahead and treat them a few times a week, but where's the data? So we actually did a study with the fixed combination of calcipotriene and betamethasone dipropionate, treated all the patients every day for a month. And in those patients who got to clear or almost clear, we then either treated them proactively or reactively. They were either treated with active drug twice a week or with vehicle twice a week. And when they got to mild disease or worse, they went back on daily treatment. What we found was if you proactively treat, even if there's no psoriatic plaques left, you're able to maintain clearance for a longer period of time. We had a proactive management reduce the risk of relapse by about 43%, treating twice a week. We also had about 41 extra treatment-free days over the course of the year. When we look at the other fixed combination that we have available, at least in the United States, it's tazarotene and halobetasol. These two active ingredients actually have a synergistic effect with this lotion formulation. what we find is we actually use the halobetasol in an 80% less concentration, 0.01% as compared to 0.05% that we normally see with halobetasol. Yet when we look at the penetration of the steroid, we find that we get similar penetration with this much lower concentration compared to what we get with the full concentration. We also find with this vehicle, when we lower the concentration of tazarotene, we actually get more tazarotene into the skin. And in phase 2 clinical trials, we found that there seemed to be a synergistic effect of these two active ingredients in this lotion formulation, where the fixed combination outperformed what we would have expected based on the results of the individual ingredients. In the phase 3 clinical trials, we saw about 40% of patients using this drug once a day over 8 weeks got to clear or almost clear. We also found something kind of interesting. We treated these patients, we started to see efficacy by week 2. At week 8, we stopped treatment, and in a lot of patients, they continued to improve even off therapy. We did a retrospective analysis, and it turns out that about 62% of patients maintain clear or almost clear a month off treatment, but actually almost 14% continued to improve during that month off treatment and now get to the clear or almost clear. So I've talked about these fixed combinations, but you might be saying, come on, I have these individual ingredients. I can layer them myself. I don't need to buy a fixed combination. The problem is when you layer two active ingredients with different vehicles, you cannot predict what's going to happen to the actives when they're exposed to another vehicle. When we look at the exposure of tazarotene and look at the penetration, we find that tazarotene by itself, the red line, penetrates the skin fairly nicely. However, when you layer tazarotene and halobetasol, we actually see a decrease in the penetration of the tazarotene when we have those two layered. You can't predict, and often an ointment on top of an ointment actually doubles the vehicle and basically cuts your active ingredients in half. So we have some really great new molecules that were recently approved. The first is tapinarof, and this was important enough to get published in the New England Journal of Medicine for a topical treatment of psoriasis. This is a new mechanism of action. It's an aryl hydrocarbon receptor agonist. This is a small molecule that actually works inside the cell, and it's been shown to do a number of different things. It's been shown to downregulate Th17 cells, very important for psoriasis. We see it decreases oxidative stress, but it also has an important role on improving the skin barrier and downregulating Th2 cytokines. So it makes sense that this drug is being studied not only for psoriasis, but also for atopic dermatitis. When we look at the main phase 3 clinical trials, we studied this drug also in an elegant cream formulation once a day over the course of 12 weeks as compared to vehicle. We studied it in adults, and we actually took all comers. They had mild, moderate, or severe disease based on their physician's global assessment, and between 2 and 20% body surface area. We see that most of the patients had moderate disease, but we had about 10% milds and 10% severes. And you have to remember, with this very high bar that the FDA puts in place, we have to get to clear or almost clear with that 2-grade improvement. That means the milds have to get to completely clear skin. That means no residual pink skin anywhere on the body. And the severes have to jump 3 or 4 categories. The average body surface area was about 8%, which is typical for a topical psoriasis study. What we found was both studies were very similar in terms of efficacy, and we saw highly statistically significant results. Up to 40% of patients got to clear or almost clear with that 2-grade improvement, and the vehicle much less, about 6%. In terms of itch, remember itch, so important for our psoriasis patients. Also an early separation between the active and the vehicle, and about 60% of patients had that 4-point reduction in their worst itch. This is an example of a patient from the clinical trials, moderate psoriasis at baseline. Remember, we're just seeing some target areas. By week 4, they went from a moderate to a mild. For a topical drug once a day, nice improvement. And by week 12, they were completely clear of their psoriasis. This next patient, I think, is one of the most interesting ones. It underscores the high bar that the FDA puts in place for a clinical success. This is a patient, and we're just looking at the hand here, had moderate psoriasis. Their itch was an 8 out of 10. And look at their DLQI, a 14. We know a DLQI above 10 means this has a massive impact on their overall quality of life. Imagine this patient walking into the AAD annual meeting with psoriasis on their hands, reaching out to shake somebody's hand. You can imagine people will jump back. Imagine that impact on this patient's overall quality of life every single day. They're using a topical drug once a day. At the end of 4 weeks, they're still moderate based on their overall plaques. But look at their DLQI. It went from a 14 to a 4. Their itch went from an 8 to a 2. By the end of 12 weeks, they went to a mild. This is a treatment failure. But this patient might be your best friend because look at the DLQI. It went from a 14 to a 1. The itch went from an 8 to a 1. Treatment failure, because it's still mild disease, shows the high bar that the FDA puts in place for what defines a treatment success. Does this work on larger body surface areas? Not that everybody with widespread disease should use a topical agent, but say you have a patient who has 10 to 12% who's not ready to go on a systemic agent. We find that those patients, whether they had mild, moderate, or severe psoriasis based on their physician's global assessment of the quality of the plaques, whether they had under 10% or over 10%, we saw very similar levels of efficacy. And also, it didn't matter whether they had newer onset psoriasis or older psoriasis, all the patients seemed to get about the same response. What about sensitive areas? Patients might have psoriasis in an area that's difficult to treat. What do you do when it's on their face? What do you do when it's in the groin? What do you do when it's under the arms? We can't use a potent steroid there. We've had non-steroidal agents that have been challenging to use because they sting and burn, and we don't always see the efficacy that we need. Here we see, in terms of tolerability, using this drug in sensitive areas, this was well tolerated. It can be used, I like to say, one-stop shopping. You can use it on the face, you can use it on the elbows, knees, hands, one drug that can be used on multiple body surface areas. In terms of the side effect profile, folliculitis and contact dermatitis are the most common side effects. Most of these were mild to moderate. And when we look at the number of patients who dropped out of the study due to side effects, the numbers are quite low, generally less than 2%. We do have a really interesting long-term study, and the way this study was designed was different from other long-term studies. We know long-term studies are first and foremost safety studies, but we also look at efficacy over time. So in this study, patients who completed the phase 3 clinical trials were allowed to enter into the long-term open label study. Normally, when a patient gets to clear or almost clear, we take their medicine away. In this study, we said, wait a minute. In real life, if I still have some psoriasis, you're not taking my medicine. I'm not satisfied with almost clear. I want to be clear. So we allowed these patients to continue on treatment until they got to completely clear disease from their disease. We then took their medication away and waited to see how long it took for them to get mild disease or worse. So the first thing, as I mentioned, it's a safety study. The bottom line was we did not see any new safety signals that occurred when patients had access to this drug over the course of a year that we didn't see in the first 3 months. But in terms of efficacy, we found something kind of interesting. Overall, almost 60% of patients at some point over that study achieved clear or almost clear. And in fact, 41% of patients got to completely clear skin. So with a topical, in patients who have heterogeneous psoriasis, it's unusual to see patients getting to completely clear of their psoriasis. But we also found something quite interesting. When we took their drug away, when they got to completely clear skin, we found that they had a durable remittive effect. So this is a Kaplan-Meier curve that looks at those patients who came into the study with completely clear skin. They had the longest runway because they went for the entire study and we could see how long it took for their disease to come back. Basically what we found was, on average, the median duration was about 114 days or 4 months. That means on average, if you get to completely clear skin, you could have a 4-month holiday from your medication. That means over the summer, if you're clear, you might not have to take your medication if you're a counselor at camp. You might not have to take your medication if you're going on a cruise. You might not have to take your medication if you're traveling to Europe. Half the patients had a longer durable remission, half of them had a smaller or shorter durable remission. But look at the 1 month. Over 95% of patients went an entire month without having their disease recur. A lot of patients went 8 or 9 months without their disease recurring. Why does this happen? It's possible, some studies have shown that it's possible that we are affecting the resident memory T cells. In some studies, it looks like we're having the remittive effect, possibly because of our impact on these resident memory T cells. So let's switch gears. What else is new? Well, we have some innovation in phosphodiesterase type 4 inhibitors. When you say PDE4 inhibitor, most people think, I've heard about that. I'm not sure that I'm that excited, but you have to realize that not all PDE4 inhibitors are the same. Roflumilast is a topical medication that has up to 300 times more potency than our currently available PDE4 inhibitors. It's already FDA approved in the oral formulation for COPD. And we have to realize that not everyone is the same, just like steroids. Just because you have a steroid doesn't mean every steroid is the same. Not every PDE4 inhibitor is the same. This one seems to be much more potent. It was studied in phase 3 clinical trials in plaque psoriasis. We studied this once a day over the course of 8 weeks. Again, once a day, a nice cream. And in this case, we actually studied patients all the way down to age 2. So we included pediatric patients, 2 to 20% body surface area, every day for 8 weeks. And what we found, again, statistically significant results after 8 weeks. We start to see separation statistically significant after week 4, and about up to 42% of patients got to clear or almost clear with that 2-grade improvement. What was interesting about these studies is we did a specific analysis of the intertriginous areas. We looked at them at baseline, we followed them over time. Again, we need medications that will treat these sensitive areas. And it turns out up to 70% of patients got to clear or almost clear of their intertriginous disease, with the vast majority actually getting to completely clear skin. In terms of itch, again, a very nice improvement in itch that occurred fairly rapidly and was maintained over time. So again, this is a drug that we can use on multiple body surface areas. Here's the elbow, here's the axilla. You can use one medication every day on multiple sites, and we see efficacy over the course of 8 weeks. In terms of safety, when we think about PDE4 inhibitors or nonsteroidals, we do worry about stinging and burning. This drug was actually well tolerated. The side effect profile, when we look at it, it's interesting to see. We do see a signal for the type of side effects that we see with oral PDE4s, such as headache and diarrhea. This can occur, and it's probably because we do get some systemic absorption of the medication, but these are generally mild or moderate and tend to go away even without treatment. We do have a year-long study with this drug, and again, no new safety signals were identified that we didn't see in the phase 3 clinical trials. What's also interesting is that this drug is currently under development in a foam formulation. Foams are great for the scalp. So we have a phase 2b study that looked at scalp psoriasis as well as body psoriasis using this medication once a day for 8 weeks. Similar study. In this case, they looked at patients who were aged 12 and up. They had to have at least mild severity of their scalp as well as their body. And what we found was, scalp psoriasis, if you think about scalp psoriasis, we all think this is so tough to treat. When you look at treatment guidelines for scalp by itself is an indication to go to a biologic agent. Yet when we think about the penetration into the scalp, anyone who does a scalp biopsy, including me, chances are fairly high I'm going to hit a vessel. And it's going to be a lot of bleeding. And that just shows the scalp has wonderful penetration. It's a very vascular area. Topical medications actually penetrate great. The problem is patients don't want to use them because vehicles can be very challenging in hairy areas. Yet with this particular vehicle, we see that up to 60% of scalp psoriasis patients actually get to clear or almost clear, and 34% completely clear. In terms of using the same formulation on the body, this drug was equally effective whether it's the cream or the foam. We see very similar results on the plaque psoriasis of the body. And what about itch? Scalp psoriasis itch is really important because of the Kebnerization. People sit and they pick at their scalps and then they spread it and it gets worse and worse. We saw a nice reduction in scalp itch that was statistically significant as early as week 2. In terms of the tolerability and safety profile, we didn't see any signals that we didn't see with the cream formulation. The foam and the cream, very, very similar. So the bottom line is I want everybody to be excited about the treatment landscape for topical therapy. We have some wonderful new agents, and we have even some additional agents in the pipeline. So thanks so much.
Thank you so much for this presentation. Any questions from the audience? Yes, please.
Which area you can use Topical?
So the question is, the question is where on the body can you use tapinarof? The good news is it's a non-steroidal option. You can use it anywhere. You can use it on the face, you can use it in the groin, you can use it on the elbows, knees, hands. There isn't an area where you wouldn't use it. We did not specifically study it on the scalp, but it doesn't mean you can't use it on the scalp. It's a cream formulation. It can be used anywhere.
But you can use all over the body, or there is an extension that you can use?
No, and that's actually an interesting question. Some of our topical agents have a strict limit on the amount of drug that can be used because we worry about systemic absorption. That's not the case for tapinarof. It's really broken down very rapidly. We don't see systemic absorption even when it's used on larger body surface areas. We did see a maximum use study where we didn't see systemic manifestations even when used on very large body surface areas.
Yeah, it's really great news, I think, that also for the difficult locations we get some innovation in the topical treatment and that studies are done. Also on the remittive effect, actually, it is so important that we get more studies done on the various aspects also on the topical treatment. Andrew?
I think for psoriasis is a chronic disease and requires chronic therapy. And the great thing is the new drugs are studied over the course of 1 year in a chronic way and can be used, on and off with long remissions. The problem is insurance companies, right? The cost differential is so different between clobetasol and the branded newer drugs. But how do you, so for me, they want to say, well, the disease gets knocked down just as good with clobetasol. It's 500 times cheaper. But it's I think a horrible choice, clobetasol over time for a chronic disease, So how do we get these drugs earlier and not have to use clobetasol?
Andy, you're exactly right. I mean, I think of topical steroids as a short-term solution to a long-term problem. It's a Band-Aid. And if you look at the FDA package insert for clobetasol, it is approved for 2 weeks and at most 4 weeks. This is a chronic disease. So what am I supposed to do at week 8? What am I supposed to do for my face? What am I supposed to use wherever? And so, especially with the fact that we can say potentially we have some data that we might be able to treat to the point of a holiday, that might end up being very cost effective. And the truth is, we didn't study this with a pulsing. Like if you got to clear and then you treated twice or 3 times a week, maybe everybody would be clear all year, and then that would be very cost effective. We just don't have that data at this point. But, it's a problem. And I'm not saying clobetasol doesn't have a place. It certainly does, but it is not the answer.
I think this is really great discussion, and I think IPC is the place to have these discussions also with this innovation in topical treatment and what will be the positions and how can the different treatment reinforce itself. Thank you so much, Linda, for this great presentation.
Thanks so much.
And great discussion.